Do you know, but I hope that at some point we'll get pulled in for failing creativity. Compliance fail is obviously not desirable, but I think when you know you're really succeeding is when you get called in for not being creative enough around a solution, that you didn't actually try hard enough to engineer something that was better and more fit for purpose. That for me would be the goal.
Hello and welcome to Pulse Amplify, where we sit down with the leaders and changemakers shaping the future of health. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, George Margellis.
Associate Professor Kudzai Kanhutu is many things at once. An infectious diseases specialist, public health broadcaster, Dean of the Royal Australasian College of Physicians, and board member at the Medical Board of Australia. Now, Kudzai is one of Australia's most decorated digital health leaders and has received national recognition for her work in refugee health, telemedicine, and gender equity. Today, Kudzai joins us to explore something that she's been thinking really deeply about and that a lot of us in healthcare are wrestling with. How do we build workplaces where people genuinely thrive alongside AI? And can AI itself become part of how clinicians grow, reflect, and lead? Kudzai, it is so great to have you here. Welcome to the Pulse Pod studio.
Hey, glad to be here. Thanks for the invitation.
Looking forward to the discussion.
So firstly, Kudzai, I've been doing a lot of thinking about clinician identity in the age of AI, not just what clinicians do, but how they see themselves. And when AI starts contributing to decision-making, feedback, it can do some tasks quicker and easier than a human. How do you think that shifts a clinician's sense of identity, their authority, and their professional judgment?
Yeah, look, it's such an existential question and a great place to start, because it's really a conversation about shifting of power and how AI reshapes the power dynamic that we have as clinicians and the identity, the authority, the sense of power that we have. But I'll reflect on this being an old conversation as well. Louise, you remember many years ago we participated in a conference where at that time the meme going around was, don't confuse Google search with my medical degree.
Yeah.
And that was a mug that people had and were kind of cheering on the profession. And what that was really is it's a reassertion of power. It's saying, I don't care whatever is happening out there. We are still very much in the seat of control and power. And now the modern version of that is, I don't know if you've heard this article that was out a few years ago calling out what's called idiot syndrome.
No, go tell us.
Yeah, it's short for Internet-Derived Information Obstruction Treatment Syndrome. So essentially calling people who are searching or Googling before they come for their consult part of a syndrome called idiot syndrome, because who are you to come with all of this stuff to my consultation that I then have to deal with as an obstruction to whatever treatment I want to put in place. And to that, I would say, if you're a sort of doctor who hasn't accepted that this is where we're at, then who's the idiot in that dynamic? And that's exactly where we are. But that power dynamic or that shift isn't operating in a vacuum. And the way that healthcare is constructed, and particularly medical power, is that there are many currencies within which it's traded. So if I'm looking at this challenge as a senior professor, somebody who's in a large academic institution, and I've had 30, 40, 50 years to build up that legacy of prestige and of eminence, I'm probably going to be relatively more resilient because I've got tenure and I've got security. Where I think it's harder at an identity challenge and at a coalface is for people who are maybe developing their careers or developing their professional identities and can no longer rely on, hey, I will always be the person who knows the most in the room. I will always be the person who is the best paid in the room. And that's where I think we really need to invest that time of negotiating that power dynamic and getting people comfortable at an early stage of their career with navigating and sharing power, because that's what this is an invitation to. Are you able to acknowledge your limitations, your power as well, and your responsibility, and power share with a patient who will be coming to you when that power or knowledge asymmetry no longer exists, that you're really having to try and level up and still establish what are the things that you can control or contribute to, what boundaries can you set, but having that sense of security of identity that is also able to be challenged, but still assert a certain level of intellectual rigor and contribution to that relationship that you're trying to build with your patient.
I think you hit the nail on the head there. The reality is our role as clinicians is shifting. And when we went through med school, we were used to the doctor being the all-encompassing guide. I remember when they demolished the Bosch Library at Sydney University. So we had a dedicated medical library.
Bosch.
But that building's gone, and that was our centre of town. That's where we had access to information that no one else had access to. And let's be honest, you can be sitting on the bus looking up a New England Journal of Medical article nowadays. So that's changed a lot. You've worked in many areas of care, clinical care, telehealth, public health, and digital. First of all, what cultural shifts have you seen that make those workplaces more AI enabled rather than less so?
It is still at that precipice where the thing that makes the biggest difference are what's the network of champions that you have leading the change. As much as the technology is coming in over the fence, over the wall, through windows, you still need an environment where people have that level of relational trust to believe that the direction that they're being taken on is a rational one and they can trust it. And I think in Australia as well, the landscape is so uneven in terms of relative digitization. You have some organizations that are HIMSS level 7, others that are still struggling on paper. So whenever someone introduces something new, the first hurdle or the barrier that needs to be crossed is the relational one. Is the person who's making the suggestion someone I can trust? Are they trustworthy? And what have they done historically to prove that this is going to be a good direction to take us on? Sometimes, though, those decisions in terms of AI enablement happen at a micro level, as in it's just the individual themselves making the call that, hey, you know what? I know myself enough, or the risk is sufficiently worth it for me to invest in making the change, and I'm just going to go and do it. Nobody needs to know. And there I'm thinking about people who might be working in private practice where you really do have that autonomy, system and organizational autonomy to make the call. Once you scale that up, though, to a hospital department where you know there is now a regulatory environment that is going to mandate at some point you're going to have to account for what you just did or the decision you make, that's when it gets harder. So the organizations where it does work well is when the connections between the regulatory decisions or those checkpoints in your mind where you're thinking, if I'm in front of a coroner, am I going to be okay in justifying what just happened here? And is the risk that I'm taking one that I can handle? It works well at an organization when the governance pieces are fixed, when the dots are connected, and when the whole environment itself allows people to make rational and sound decisions. And that's just a for now thing, because I think at some point things become quite naturalized. So if you've had an EMR for 10 years and somebody adds in an AI bell or a whistle, an alert, no one's really going to think too much about that. But if you are going from paper and then somebody happens to be using an app to drive clinical decision making on the side, it's a little bit harder because those dots haven't been connected and there isn't that sense of an authorizing environment.
Kudzai, you're really interested in the AI when it comes to its role in not just culture, but in coaching. And so I'd love for you to talk us through your thoughts around culture and coaching in an AI-enabled workplace. And we know that healthcare can be very hierarchical and time poor. So what's the role that AI could do that would actually help create more positive learning environments?
Yeah, look, why it's a hard question to answer at the moment is we're working in a really complex regulatory environment and increasingly complex. So on the one hand, you've got organizations like APRA, we've got government edicts, we've got cybersecurity recommendations that are operating at an organizational level. And then within the workplace itself, you also then have safe work recommendations and legislation that are really around psychological safety and creating positive work environments and cultures. So what we used to do in the past in terms of creating an enabling environment or a coaching environment was largely punitive. Certainly in the medical spaces, you had to know what you were doing, and if you didn't, someone would yell at you. That's not going to work anymore. So that's why I think that coaching mentality becomes increasingly valid and important, because it is essentially about making a commitment at an individual and an organizational level to lifelong learning. And lifelong learning is about first setting some goals for your coaching journey or whatever it is you're trying to achieve. And also implicit to that is that sense of positive psychology that you can improve, you can do better. And with the help of AI tools, they may actually be part of the resource or the capacity that you develop to create space to do that. So it's very hard in a busy work environment to ask people to do more. But if what you're saying is, hey, we can maybe offload some of the cognitive load that you have at the moment that is preventing you from doing another task, and hand that over to an AI tool. And that's been really clearly done well in primary care, where people are using scribes to offload some of the cognitive load so that they can then dedicate their time and their effort towards patient care or carrying out other tasks that are equally important to them in their day-to-day life. So it's finding that balance of where is the opportunity where AI can be put in, and at the back of your mind, retaining that coaching mentality of, hey, I can work on this, I can improve, and there is a way out of this. And when and how do I deploy AI to actually create that environment where I'm able to learn and shift myself and grow in a positive way?
One of the big things around coaching is this concept of nudge versus just throwing a lot of information at people. Are you seeing AI tools sitting in the background, just nudging, helping decision makers think about this or have a look at this article?
So I think it's that dynamic of push versus pull technology. And at the moment, I think people are still reaching into the basket to have a look at what's in there and then pulling things out. I have not yet seen an environment where it is actually observing the individual, observing the workflow, and then making suggestions on improvements. What you tend to get is more of a compliance push or a compliance-driven notification. Hey, you've just maybe prescribed a little bit too much. And a lot of that will have built into it some logic that has been built by people that then may or may not have an AI overlay over the top of it, but it doesn't yet know the individual to know that this person here is totally fine to prescribe that. They know exactly why they're doing it. Don't send that prompt because this particular individual is at a skill level and a maturity level where they know why this is happening. So at the back end of that support, there is still a set of rules that are set at a very generic level. And I'm yet to see that evolution of systems to actually be able to relate to the individual so that they feel that the prompts and the recommendations they're getting are actually personalized. They are still in organizations set at that very generic and the lowest possible risk threshold level, which is the right thing to do. But I would love to see it evolve to the point where somebody who has literally prescribes that same drug every day, all year at that dose, is still not getting the same advice or recommendations sitting at the back end of it just because that's the organizational policy.
Yeah.
We've been talking about alert fatigue for many years, and the reality is if you keep alerting everyone about everything, then basically the alert loses all value.
Yeah, like we have to make sure that as we're putting AI layers in, there's a way to be way more sophisticated in its application so it doesn't add to the fatigue and add to the burden.
Yeah.
So a lot of these AI tools in aged care are making sure people meet policy compliance. The reality, unfortunately, sometimes the policies are 10 years out of date. So they're now complying with policies that are out of date and actually detrimental. But we have a very compliance-driven industry. You get dragged in front of the medical review board for failing compliance, not necessarily failing patient care.
But I hope that at some point we'll get pulled in for failing creativity. Compliance fail is obviously not desirable, but I think when you know you're really succeeding is when you get called in for not being creative enough around a solution, that you didn't actually try hard enough to engineer something that was better and more fit for purpose. That for me would be the goal.
That's perfect. And have you seen examples that come to mind? Because it'd be great to use and have technology enabled so that it manages the risk so people can trust and know that the risk is managed and feel freer to be more creative.
Do you know where it did happen? And it was because people were left with no choices. It was COVID. I cannot think of a time where I saw people be more resourceful and more creative to think outside that box of, oh, that is an ophthalmologist. Surely they can only do eyes, to, well, you know what? That person potentially has the skill set to do a whole lot more. How are we going to get there? And can you imagine what it would be like? And it will happen. We will have another pandemic at some point. Yeah. Can you imagine having that same experience with the benefit of AI to be able to, for example, look across the entire healthcare workforce and identify based on employment history the people that you could draw in to mount a pandemic response based on where have they worked, their age, their medical conditions, and information that they have willingly provided over time to say, hey, you know what? We've got a major crisis at Hospital X. We need somebody who's got experience with ventilators in the last 5 years, and to be able to reach out to those people within 48 hours and say, are you willing to come and work across here because we need you? And we know, based on the data that we have, you're actually in a really good position, and we could coach you with an AI tool before you arrive at the hospital, do your onboarding, and you've done that work. Instead of what we did was we got there, but geez, it was slow. It was slow, it was deliberative, it was clunky at times, but we got there. But there was that exercise in creativity that went beyond compliance and dipped into, the compliance challenge is actually we've got to be creative. That's the new goal, not that we just have to make sure that we've put people in hospitals and people are working. So it can happen. And sometimes it's that, can we do a dress rehearsal of the same thing while we still have time, and to try and weave in, for example, a disaster response that has AI embedded into it. How would we do things differently?
You touched on some interesting points there, because we tend to think about AI as a clinical support tool, but there are so many other aspects of healthcare delivery that we just don't consider. I remember when I was working in the private hospital space, we had all these things that make sure the clinical care worked, but we ran out of linen because no one managed the linen. So the whole hospital stops functioning when you run out of linen. It's those sort of small things that you don't take into account.
And are these conversations in your role as dean and also your board director role? I'm just thinking that one example of using AI to harness the information that people would provide willingly to actually mount disaster response. And then it could also be used to help people with their career development. If we have this pool of knowledge that AI can leverage, are these the types of conversations that we are having or that we need to start having though?
People are having them. And I think especially in the regulatory space, one of the areas where I see that willingness to use or deploy AI is in the area of sentinel event prediction, or trying to see into trends that are emerging that have not yet risen to that level of human insight and visibility. So it's looking at data and trends, assessing large volume data to see if there is a signal. Cosmetic surgery was one where if we went back in time and we had that ability to try and see what was happening on social media across multiple platforms, you would have seen that there were trends emerging there that were essentially risk trends. So the regulatory space is very much attuned to how can we get better at predicting early on when something might be going wrong, or also on the flip side of that, identifying people who are doing really well. Like, how come this hospital exceeds and it always delivers really well? They don't have more money. So what is it that's going on? And then I think the next piece and the extension of that, where often things fall apart, is the connecting the data dots and then actually having that ability to transition out of just data mining pure to, we're now going to go to that facility and we are resourced to do that final bit of work, which is to be in the physical environment and see if the hypotheses that you have built at actually make sense. Does it render true? Or is there something that's actually really peculiar that's going on that is explaining that trend that you're picking up on? So I'd say definitely in the regulatory space, there's a rapid regulatory response unit that is really about trying to test the boundaries of how do we get better at detecting things and being really proactive in prevention and providing the best possible outcomes for people in community. And then on the other side of it, you'd asked about individuals and their career or their professional development and how that's playing out in health, pedagogy, teaching, learning. Yes, absolutely. So a lot of the newer software providers are looking at when somebody is going through medical school, for example, how are they performing on certain assessments and starting to make predictions about someone's likelihood of actually progressing to the next stage based on how they've been going. And I think the richer versions of that actually give the person real-time feedback so that they're actually able to adjust, because it is a huge waste in time for somebody to have gone through a 2-year program to then fail a barrier exam. You should have known that 12 months out that this person looks like they're not getting there. What can we do to remediate so that they're not wasting their time and we're actually intervening in a timely fashion? And it's that ability to pull together different forms of evaluation into one area where the person can then see the full picture of themselves. Because I think we all have blind sides as well. And I feel that's where AI can fill some of those gaps. You're thinking to yourself, geez, I'm a top performer, but there's somebody in your ecosystem who is seeing you in a different way. Wouldn't it be helpful for you to know that? Because that is what is going to be the barrier to your progress. And I can see that's where systems that are AI enabled can help to bring some of that together in a way that sort of feels safe and curated in some sensible way to support your growth.
Fantastic point. I've been mentoring some young postgrad medical students, and the reality is our decisions around careers are often driven by factors that are totally wrong. We're going to become an ophthalmologist because they make $1 million a year and they get the weekend off. No, you don't have the skill set for that.
Yeah.
Really fantastic discussion.
Well, time for a quick break. And when we return, Kudzai is going to discuss her ideas for using AI as a mirror for how clinicians are performing to help with professional development. We're also going to discuss some high-level leadership lessons for the C-suite when it comes to deploying AI and the importance of clinicians to nurture your mental health fitness. Back soon. I want to make sure we also talk about clinical decision support and your idea around this, Kudzai. The wider conversation around clinical decision support is mostly around AI supporting diagnosis, treatment decisions, and as we've been discussing, should be used more for workforce planning. But you're also really interested in something really inward-facing for healthcare, which is AI as a mirror for how clinicians are performing and relating. So can you unpack that for us?
Yeah. So a good example is I used to do a clinic in Footscray, which was a refugee and migrant health clinic. I did it initially once a week, and then over time I added on new things to my work portfolio, and I was dropping the hours so that it was once every fortnight and then variable. That's fine, but what it does is that it leaves you in a very precarious position as a clinician in terms of your feeling of being competent in that space, because what I was really converting myself into is a low caseload specialist. And a low caseload specialist, in my mind, is the experience of always feeling like you're not quite on your game. What I really needed in that experience was some way to curate over the top of my holistic experience of, yes, I'm still doing hospital work, so I'm getting experience from there. Yes, I'm still doing HIV care, TB, complex Hep B care in that community clinic. And where are my gaps? I was no longer able to see myself. And when you're in that clinic by yourself, and people expecting you, you're turning up as a specialist, right? People are knocking on the door. Hey, can you have a look at this? What do you think? And it was that realization that you can feel very alone and isolated. And I've had similar conversations with other people who have achieved specialization, who then, because of the way the career takes you, find that there are parts of their cognitive muscle that is not where it used to be, but you have no objective way to actually see into that. I would have loved at some point to have a summary at the end of the year. These are all of the patients that you saw. These were the top 3 drugs that you prescribed. This, as far as we know, are the outcomes for these patients. On that basis, we actually recommend that you need to go to this conference or speak to this person who is 10 kilometers away from you, who is doing a lot higher caseload than you and could really help you to fix some of the gaps that we think might be emerging for you. That for me would have been like amazing. And that's exactly what I've needed. So when I think about that visibility across multiple aspects of who you are developing into as a clinician, I would love to have some sort of aggregator that could have done that or supported that for me. And I know because the data is there, right? It's everywhere. I'm constantly feeding data into the data machine, but I never had that opportunity as a professional to actually see into that, whether it's what did somebody say on one of my feedback forms. I gave someone advice yesterday. Was it good, bad? What was the outcome? What happened next? And I would love to use some sort of aggregator, really an intelligent system to help me to do that better, so that when I'm doing a professional development plan for this year, it's somehow informed by something more than other like the vibes of how I think I'm going.
That's really interesting. I remember reading a statistic many years ago that 90% of doctors consider themselves to be in the top 10% of their profession. So therefore, it's very challenging for us to consider professional improvement. But just the transparency, having information about what our outcomes are like and what we've been doing and building those relevant networks so that we know who to go to. Now, unfortunately, sometimes in our medical culture, we are not keen to ask for help. But the reality is, in a connected world, that's something that's really important. I've just recently been reading Dr. Wachter's new book, The Giant Leap. One example he uses was the sepsis model that came out of Epic a couple of years ago, where it looked like it was going to save the world. But when they actually started rolling it out across other factors, it didn't work. Brings us back to that question about how specific AI needs to be to your work environment and how you need to engage with the people within your environment. What's your experience been with those sort of tools that come from outside, get dropped into your lap, but don't actually deliver the care or services you want from them?
I'm part of the sandwich generation, right? You're here where you are, but you're helping look after older people, you're helping look after younger people. And that introduces you into a lot of different healthcare environments, and you get to see how things play out. One of the institutions I've been to fairly recently, I would say is considered to be one of the premium health institutions in the country, if not like Southern Hemisphere. What I observed is that into that system where you've got all of the bells and whistles technically, people operate in curiously divergent ways. So one practitioner comes in, does a procedure. Next practitioner comes in, does the same procedure in a different way. And I'm like, no one's seeing this, right? No one's seeing this.
Yep.
But that first person did the same procedure in under 5 minutes. The second person, it took them 15. You can't see that. You actually have to have been there, asked people and shadowed people enough to understand what you're asking them to do. So asking the first person to do something extra, well, I'm fine. It only takes me 5 minutes to do my job. The second person, they struggled. It took them 15. But they're working in the same environment and nobody is actually able to see to that level of detail. And it's not that nobody can see into it, it's that we often don't do that contextual level assessment and evaluation that allows you to see what happened here. So the case that you've presented there, the questions I would have asked is, as we're implementing this new thing, what are we going to be looking for as evidence that it's working? And what is the chain of evaluation at the creation, the inception phase, the early implementation, and at every time point? And have we got really close to the people that are going to feel the worst harm if this isn't working well? How close are we to them? Because often a lot of these decisions happen at a C-suite level where the decision-making authority exists, but it doesn't involve the people where the pain is genuinely felt when things aren't doing what they're delivered. So I've had the exec team come. They promised me they're bringing this amazing new sepsis module. It's going to be amazing. It's going to save patient lives. Oh, wow. But you can't make the decision, or I don't think you should be making a decision alone when you're not the one who's going to actually have to do the mechanics of the delivery and the final piece of that puzzle.
Part of the challenge there, obviously, is that you may well have executive suites who haven't been in an ED or an ICU for 20 years. They may have a clinical background, but they've moved away from it and the world changes.
We struggle with power sharing, but sometimes what I'll say if I am having a C-suite conversation is, don't think about it as you handing over power. Think about you taking the responsibility that is required when you are stewarding and supporting others. That I will not lead you somewhere unless I've had a conversation with you about what opportunities will you have to tell me, hey, you got it wrong. You didn't get it like a little bit wrong. You got it way wrong. And if you're not able to do that, I don't think you're exercising your true kind of executive powers unless you're able to say, when will somebody get to tell you, hopefully very early on, not that they get to make the final decision, but you still leave that space for someone to say, hey, look, I noticed something that's not going to plan. How will I tell you that? And that there's a space and a time that's already been pre-dedicated to that. Because once the wheels start to fall off, it can be really hard for people who are impacted to say, you know how you spent millions of dollars? Well, just something. It's not going to happen. So you have to pre-fashion that space so that people know that there will be a moment for them, and hopefully many moments for them to just give you a wave and let you know how things are really going.
I guess a key word there is leadership, having leadership that actually has that capability, and that's very important.
Yeah. Well, I was just going to say trust also. So there's leadership in that, but also so much trust. Trust in yourself, trust in others, trust in the system. This is such a fabulous time to be alive right now. I know there's so many bad things happening in the world, but when you look at just this conversation with you, Kudzai, I'm so inspired by your thinking around how AI could be used as a tool, not just as a clinical decision support, but to really support clinicians to enjoy their jobs, to have that 360-degree feedback, that review, to be mentored and coached by others senior to them and have actual data to draw from that could actually enhance that trust in that relationship and help to break down those traditional grasps on power. It's very exciting.
When do we get started, Louise?
I know. Well, this conversation will inspire heaps in the audience. So probably just the last thing, if you wanted to comment on, Kudzai, like final thoughts. We have so many executives as well as healthcare workers who listen to the pod. So what would you like them to, if they're going to take away one thing, or what should they be thinking through and understanding about learning and AI right now?
I'll tell you something first before I answer your question. Do you know a lot of Zimbabwean names end in AI? Mine is case in point, right? Kudzai.
Huh.
As much as my name ends in AI, the world doesn't have to end in AI. So I'd say nurture your mental fitness. Really nurture your mental fitness. There is sometimes an overwhelming feeling you get that, oh my goodness, everything's about to change. I'm going to outsource every part of myself and my being. You still exist. Like, this body is still here. This brain that is many millennia old and has come to this point of being still exists. And pay that the respect that it's due. You just now have a new series of tools with which to play with and to explore with, and for us to take ourselves on the next journey as a species. So please nurture your mental fitness. If there are aspects of thinking that you really love, keep doing them. Keep working those muscles. Don't feel like you have to outsource them because somebody in your office happens to like outsourcing that aspect. I like writing my own emails because it's like I'm connecting the thoughts in my mind and making a commitment in words to someone else that I hope they will receive in the best possible way. So I don't mind doing that. I don't need Copilot to pre-draft something, because often Copilot doesn't really feel like me. Yes, it's faster, but I like doing that. I like the mental effort. If I'm invited to speak somewhere, I still like the thinking around, what will I say? I don't really like to pull 100 different papers and then say, give me a summary of all of these papers and what are the key things. Yep. I really like to take a seat back and think, oh, okay, what's it really meaning to me? If you're asked to do a keynote, you can say, yes, doing a keynote, again, that is something that I take so seriously that I will always think really hard about if it's a yes, because I know it's going to take a huge creative effort. It's effortful. And I think when I say nurture your mental fitness, it's about deciding which muscles you really want to continue to grow and which muscles you don't mind are a little bit atrophied, because it's going to happen, right? But you decide. It's okay to still really want to do stuff that's a little bit hard that maybe isn't AI assisted or facilitated, but just be choosy. And it's okay to be choosy about what you do and don't do, and what fitness you want to preserve and what stuff you're happy to let go.
I think that's great advice. The reality is that actually enables you to be resilient to the changes ahead of you.
Wonderful. Kudzai, you have an amazing mind to see your career just continuing to flourish because of all this hard work that you put in. And I love that your focus on creativity as part of that process in a way that we don't often think about or talk about in medicine. We don't really think of it as a creative pursuit, and it so is, and to do it well. So thanks for coming on the show today and exploring these ideas with us.
Well, thank you for your creativity and leadership, Louise. And lovely to see you, George.
Great to see you again. Yep. And looking forward to further discussions.
Definitely further discussions. Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by me, Louise Schaefer, with audio engineering by Ivan Jurek of Octopod Productions. Big thanks to Emily Mara, co-founder and publisher of Pulse IT News, for all of her support. And a big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcasts. Tell a friend, share an episode. We always love to hear that that's happening. And don't forget, you can visit pulseit.news anytime, 24/7. They are there writing about the latest goings on in the digital health community across Australia, New Zealand, and now Ireland. Seriously, everything you've ever wanted to know about what might have happened 5 years ago, 7 years ago, or yesterday, you will find it at pulseit.news. Send any feedback or topic suggestions to pulsepod@pulseit.news. George and I always love to hear from you guys.